Welcome back. This is part 2 of a 2-part series on esketamine basics for healthcare providers. In this video, we'll talk about medication contraindications, adverse effects, administration and monitoring, and key components of the REMS program. Esketamine is contraindicated for patients who are allergic to the medication, individuals with severe hepatic impairment, or those who are pregnant and breastfeeding. It's not recommended for those on dialysis or individuals who could be at risk with a sudden increase in blood pressure. Because a temporary increase in blood pressure is a possible side effect, it's a good idea to delay treatment if blood pressure is more than 140/90. Taking stimulants or MAOIs can increase the risk for blood pressure elevation. Esketamine causes sedation in up to 61% of patients. Patients taking benzos, hypnotics, or opioids with esketamine may be at increased risk. A temporary mild increase in blood pressure is a common side effect that can occur at any point in treatment. Hypertension is most likely to occur at peak serum concentration, which is around 20 to 40 minutes after administration. Due to the risk for high blood pressure, monitoring includes assessment of vitals at baseline and before monitoring completion. Blood pressure specifically is measured 40 minutes after administration. Dosing consideration should be made for patients with a history of hypertension and older adults, as these groups are at increased risk for significant blood pressure elevations. Tachycardia is a less common side effect, but it can occur. Sedation and dissociation are common side effects of esketamine, affecting about half of all patients. Both sedation and dissociation are assessed throughout the 2-hour monitoring period. At enrollment, patients sign a REMS agreement stating that they understand the risk of these effects and will not drive after treatment. Before moving on, I wanted to have a look at the patient monitoring form, which is used in outpatient settings. It's completed within 7 days after each treatment. Here you can see where the provider identifies if the patient's taking any medications that could potentiate sedating or hypertensive side effects. A set of vitals must be taken prior to administration and at the end of the monitoring period. Blood pressure is also measured before treatment, 40 minutes after treatment, and before monitoring completion. Sedative and dissociative effects are reported on the REMS form. If present, you do identify when the symptoms began, when they resolved, and if any treatments were given. You're considering esketamine for a current patient that is having difficulty at work due to symptoms of TRD. Before starting esketamine, it's important to advise the patient that A. Treatment benefits may take 6 to 8 weeks to occur. B. After treatment, sedation may be present for up to 12 hours. C. Transportation home must be arranged before each treatment session. Or D. All of the above. And the answer is C. Like ketamine, esketamine does have a risk for drug diversion and recreational use. REMS guidelines limit who can dispense the medication and require administration under supervision. Facilities that give esketamine are required to keep records on medication received and given. These facilities can be subject to random audits by REMS officials. Our last black box warning is regarding suicidality in young adults and people younger than age 18. Esketamine is indicated for major depressive disorder with suicidality, but it's not a replacement for hospitalization. If your patient is suicidal and is at risk, they need to go to the hospital. There's quite a few studies right now on younger populations, but we haven't seen the results come out yet. In addition to the side effects already discussed, other common effects can include nausea or vomiting, headache, discomfort in the nose or back of the throat, loss of taste, and dizziness or vertigo. A 72-year-old patient is experiencing severe depression and anxiety due to concerns about an unresolved abdominal aortic aneurysm. Before prescribing esketamine, consider A. Need for cardiac clearance prior to treatment, B. starting at a 28 milligram dose to minimize the risk for adverse effects, C, both A and B, or D, I would not recommend esketamine for the patient. And the answer is D. There are some manufacturer guidelines about treatment initiation. Most patients will get 56 milligrams on their first treatment and increase to 84 milligrams on their second dose. Someone over 65 or who has liver disease might start at 28 milligrams, which is just one device. Patients start out getting 2 treatments weekly for a month, then decrease to once weekly if tolerated. At 9 weeks, it's recommended that patients decrease to 1 treatment every other week. There currently aren't clear guidelines about how to stop esketamine. Esketamine can cause nausea and vomiting. In order to minimize the risk for aspiration, it's recommended that patients avoid eating or drinking before treatment. Patients shouldn't drink alcohol on treatment day, and they can't drive until getting a full night's rest. This image is directly from the manufacturer. Before administration, staff check to make sure there are 2 green dots present on the side of the nose spray. The 2 green dots indicate there are 2 sprays left in the device. The patient blows their nose, reclines 45 degrees, pushes on the opposite nostril, breathes in, and self-administers 1 spray. They then wait 5 minutes and administer a second spray in the other nostril. 1 spray can be given every 5 minutes until the full dose is reached. When the patient arrives on treatment day, they typically have to come with someone who agrees to drive them home. Vitals are taken and potential medication interactions are assessed. The medication is administered with a 5-minute interval between each spray. Staff will watch while the patient self-administers the medication. After administration, the patient is monitored for 2 hours for adverse effects. To enroll a patient in REMS, the provider fills out a form. They assess history of esketamine or ketamine use, prior allergies or side effects, medical contraindications, and potential medication interactions. The patient signs an enrollment form, which reviews expectations for in-office monitoring, potential for sedation or dissociation, transportation requirements, and REMS reporting. Enrolling a facility in REMS requires a physician, PA, nurse, or pharmacist to be a point of contact. Facilities are required to keep detailed records on medication received and administered. Healthcare personnel must monitor administration, and a prescriber has to be present in the building when administration occurs. Facilities must have written esketamine policies and document staff training. Outpatient facilities are required to complete a patient monitoring form within 7 days after each treatment. For inpatient settings, administration and monitoring protocols are the same, but a patient monitoring form is not required. I hope that this brief review was helpful to you. Next, there are a few questions, and to thank you for participating, there's an optional gift card drawing.